Good morning also from my side. I think the field was opened yesterday with the wonderful talk from Jacques Bergman. Less is more. You continued, Michael, in the same direction, and so I will show some new data, but I cannot show everything. So I will not cover all the topics listed on this slide. And I will first talk about adenomatous polyps, the conventional ones, and just briefly, non-advanced adenoma. That's a small tubular adenoma with low-grade dysplasia. And if you have one or two of those, then it's the low-risk adenoma group. So here on this slide, you can see a summary of the different GI societies guidelines for surveillance. And you can see there is pretty much agreement, concordance between the different guidelines regarding the high-risk adenoma group. But when it comes to the low-risk group, then it's quite a difference. And it's also different between the ESG and our Swiss guidelines. In the past and now in the actual guidelines. You can see it was expanded from 1 to 2 until up to 4 small tubular adenomas, and above that the time interval was extended for up to 10 years. So what the critical aspects therefore are multiplicity. Can we really expand that up to 4? And how about the Willis histology? Because this histological criteria is not used anymore in our guidelines and the ones from the ESG. So this is a large US study and showed no significant difference in the absolute risk, both for incidence and mortality, between patients without any adenoma and those with low-risk situation, where there was a significant increase in incidence and mortality with high-risk adenoma in high-risk adenoma group. I will, for time reasons, skip several slides. This is a meta-analysis summarizing the data from several studies. And as you can see here in the upper figure, for the low-risk situation, there is not much difference, whereas for the high-risk situation, the adenoma risk is threefold increased. And when you move on to mortality, you can see there is no difference between those without any adenomas and the low-risk situation, where there is a significant increase, 2.7-fold increased risk for mortality associated with high-risk situation at index colonoscopy. So taken together, I would say we have quite solid data that up to 2 small tubular adenomas, that's the low-risk situation, there is not an increased risk for incidence and for mortality. So how about having more than 2 adenomas, small ones, non-advanced ones? And this is a large study from the US, and as you can see here, also for when you look at 3 or more small adenomas, both the risk and the mortality is not increased when you compare to the general population. This is a meta-analysis, as you can see here, and there is also no difference when you look at incidence, and is also no increased when you look at the mortality. So this is another meta-analysis that has just been published earlier this year. And as you can see from the different features that are characterizing a high-risk situation, mainly size, particularly larger than 2 centimeters, and the presence of high-grade dysplasia are associated with the risk for metachronous colorectal cancer, but not multiplicity. And of course, the consequence is if you include multiplicity, then you have a high number of number needed to screen to detect an additional metachronous cancer. So what's about the villus histology? As you can see here, this is data from UK study. And you can see here there is no increased risk in the multivariable analysis for this criterion of villus histology. And this also holds true from this Polish study. No increased risk both for incidence and mortality associated with the presence of villus histology. I will now move on to the serrated polyps, which is an umbrella term for a different type of serrated polyps, and the features of serrated polyps associated with an increased risk are mainly size, the presence of dysplasia, location, and the subtype, mainly SSL and TSA. So these are the current guidelines from US ESG and our ones in Switzerland, and you can see once again there is quite an agreement what is the definition for the high-risk situation, but there is a difference between a low-risk group. And the major difference is that the US guidelines, they differentiate between whether it's a hyperplastic polyp or it's a sessile serrated lesions, whereas in our and the ESG guidelines, we just use the serrated polyp group as a whole. So the question here is the critical aspects: is the risk for development of metachronous cancer after baseline colonoscopy same for HP and SSL? And again, the second question is, how about multiplicity? In this large Swedish study, as you can see here, for mortality, there is no difference as whether you have a HP or an SSL at baseline endoscopy, where there was a little bit increased risk associated for hyperplastic polyps when you adjust for a family history of colorectal cancer. When you look closer at the data, then the risk is only associated when the hyperplastic polyps and the SSL are located in the proximal colon. The problem of this study is that we have no information about polyp size, the presence of dysplasia, and multiplicity. So we don't know if the increased risk associated with for example, hyperplastic polyps, is it really just a matter of size, or is it holds true also for smaller ones? This is another study that looked at serrated polyps as a whole group, and as you can see, location and the number of serrated polyps was not associated with metachronous colorectal cancer risk, whereas size larger than 10 millimeter was associated with an increased risk. So we have now much more data as compared to our previous baseline guidelines. And the current data are not based on the high-risk group, but are based on data from a harder endpoint, that is colorectal cancer incidence and mortality. However, we have to keep in mind this also has some potential problem with the lead time bias that is increased. And so I think the data is quite nice to increase the low-risk group from 2 to 4 small tubular adenomas, as shown here. Nevertheless, the data are not perfect yet, because we have to wait until the end of this decade until we will get the first results of a randomized control trial, which is comparing different intervals for same polyps. So what else after size and polyp subtype and dysplasia? How about adenoma detection rate? Michael already mentioned this. It's a very important criteria of our work, quality control measurement. And here are just two studies. And you can see whether you are a high or low performer. There is a marked difference. And you can see on the right side, it's the same, the adenoma detection rate and the risk for metachronous colorectal cancer is associated. Maybe there is a plateau of around 40%, but at least the aim should be to get 8-year of 40%. What else then about looking closely and have a higher adenoma detection rate? Well, we don't include lifestyle information to tailor recommendations. We don't include genetic factors. So there is a large field to improve, but the other question, as it was just stated before, is what is the acceptable risk for what you can accept as a risk for metachronous cancer? If you go for 0, it is never ever possible. As we can heard just from screening, we cannot reach 90%. And so this is also a debate that has to go beyond our scientific data. Thank you for your attention.
Okay, please join us here. I think after these 2 lectures, everything seems to be clear, Michael. So we hear that we focus on small adenomas. They have a normal prognosis, so it doesn't matter. We don't do well in advanced adenomas because the risk is still increased. So is it surprising that Nordic didn't do so well?
Okay, so there's a lot of things here. First of all, I think Nordic did pretty well. I think there's definitely too much surveillance for the small adenoma patients. I mean, the whole field is very interesting. If you think of it conceptually, we remove adenomas, and we believe in the adenoma carcinoma sequence, Thomas. I think the 3 of us believe in it, so that most cancers come from adenomas. Hold on, that's my point. So almost all cancers come from adenomas, and from that follows that if you remove all adenomas, there will be less cancer. The Nordic studies showed that. It's not perfect, it's not 100%, but maybe it's 30, that's pretty good. But look, we don't do colonoscopy every day in all these patients. We talked about that in the taxi yesterday, we could just leave the scope in and then just, oh, there comes one, then we take it out. That would be fun. Then we may be reaching 100%, but we don't do that for obvious reasons. So there will never be 100. And so then the question comes in, so who are the folks with the highest risk? Because we all have to accept some risk in life. We cannot live with 0% risk. And the pandemic made that very clear. We have to live our lives. So I think the people with the small adenomas, we can just leave them. Because as you just pointed out, Kaspar,
or the adenomas?
No, the adenomas have to come out. Okay. First colonoscopy in your life, not at age 25, but maybe 50 or 60. If you don't have adenomas, all small ones, you should never come back.
Done. Okay.
You're done. That will relieve a lot of workload for the other people with the large adenomas. And there, I think, this is a monologue. Coffee is postponed. There, I think, it's far too complicated. What you showed, the tables and everything, and the villas and the size, is it 10, is it 15, is it 20? What about this and that? It's too complicated. Let's make it easier. And I think looking at the data, what I think we should do in the future is say, well, the people who have adenomas or serrated polyps, for me, that's not a difference, really. The risk is the same. Over 2 centimeters, that's the high-risk people, and the high-grade dysplasia. Everybody else is smaller risk.
Okay. So we have 3 risk groups, basically. So all the low-risk stuff is goodbye, never come back, which is not the case. And then we have 2 risk groups. So you eradicated the villus histology, which I've never understood.
Yeah.
That's probably nothing.
Yeah.
High grade is the bad thing,
right? The majority of villus histology is associated with large polyps and the presence of high-grade dysplasia. So it's mostly not an independent risk factor.
And size 1 is maybe a little bit, so size 2. So we have a high-risk subgroup among the advanced ones, and the low-risk subgroup among the advanced ones gets 5 years, and the rest maybe even earlier, no?
Yeah, I don't know about that middle group. I think we should focus on that high-risk group, the 2 centimeter high-grade dysplasia.
But
that's what the highest gain is.
Can I challenge you, is it wise to do in the high-risk group a 3 versus 5, or should you do a 3 versus 1 year in the high-risk group?
Oh, that's a good question. I don't think we have the answer, but like if you ask me what I think, my opinion, there's no evidence, I think 1 year is too early.
But tell me, one thing we forgot actually, and you mentioned it on the side, the advanced adenoma resection 3-year group rests on a complete resection.
Yeah.
So in all fairness, and if you are a perfectionist, it should be a histologically proven R0 resected en bloc. And then,
True.
the polyp is gone.
True.
Well, I would say the baseline colonoscopy quality is getting more and more important. If this one is sophisticated, then we are on a better basis to extend our intervals.
But if you think this to the end, this would mean a piecemeal resected large adenoma comes back when?
I don't think. What is piecemeal? If you have several pieces, then it's really piecemeal.
Yeah.
If it's just you have 2 pieces, clear margin, I don't think this is piecemeal.
Which
is
margin? I mean, it's.
This is.
I would trust, if you have a high-quality endoscopist, I would trust that person.
Yeah.
The endoscopist has to write in its report, okay, I've looked this over, take photograph, there's nothing left here, it's an R0. Piecemeal, period. If you have a good quality system for your endoscopists.
Which, as a fan of evidence, you should prove in a study that that's true.
Yes.
Okay.
But there's another thing here which comes up, which is really interesting, and we talked about this by email. I have no solution for this, but this will bite us in our asses. So here's the thing. We have ADR and all that stuff. We're setting out our quality systems. We are measuring ADR, you and me and you and everybody. We still, all the surveillance is based on the patient characteristics, the polyps, the size, what we talked about. But you saw it on the last slide. It's really about the endoscopist. So today, if you are a very good endoscopist, you have a very high IDR, your patients are coming back earlier than your neighbor endoscopist, who is a poor one who doesn't find the polyps. He has a lot of normals. And that's a big problem, both for the patients in the first place, but at the end it's a problem.
There's no difference,
but look, at the end it's a problem for us, because now you have 10 endoscopists, and you see that 9 of them are very good, 1 is not so good. And then you have patients that have been at that number 10. What do you tell those people? I'm sorry, we found 2 polyps, your neighbor had 2 polyps, but he was at a better colleague, so you have to come back there and there. What would I do as a patient? I would call you and say, Thomas, I don't want to go back to that guy, I want to go to the other guy.
Right, but on the other hand, is the difference so big? If you have an 85% adenoma detection rate, only small polyps, and the other guy has a 40%, also small polyps, and in theory, there shouldn't be much of a difference.
40 and 85 not, but if you are down at 15, then
okay.
you have a
but
problem.
that's consensus.
Yeah.
So there's the limit is probably now at 30 or something.
Somewhere,
yeah?
I would say.
You shouldn't be below 20 for sure, probably not below 30.
For average risk population, it should be somewhere around 40.
But what do you do with these people? You fire them?
The endoscopists?
Yeah.
Well, if you can afford, if you have enough others, then yes. Sorry.
Thank you for both presenters for their study. My name is Matthias Sauter from Zurich. Thanks for both presenters for their study, for their presentations. I have a question on the screening study. I actually found in the additional data, I found a table about which cancers were early stages, intermediate stages, and late stages, and I was surprised to find that in both groups they were actually quite equal. So usually we see in the screening population we see more early cancers, and there was no real difference. Can you explain that? May that be part of the problem, that some people had some symptoms, then went to the screening, and we were actually not looking at asymptomatic people, but at people that needed a colonoscopy for symptoms, and just found the letter in the mail and said, okay, I'm going to do the colonoscopy.
Yeah, thank you for bringing this up, and congratulations, you read the paper really well. Yes, it's there. I cannot totally explain it. It was surprising to us. I think it may have to do with self-selection, what you just described. Some people come, some people don't. We see that a little bit. If you also saw, we have curves for Poland and Norway. Obviously, the Polish people who came were at higher risk. Maybe they had some symptoms that they didn't tell anybody about. We had symptoms as an exclusion criterion, but of course,
But on the other hand, that's the same problem in every screening study. So we looked into this in our Berlin group, and 10% of screening patients had symptoms, which is not so much, but yeah.
But I can't totally explain it. Yeah.
What?
Michael, as far as I remember, about 1/3 of the endoscopists in your study had a ADR below 25%. And did you make a subgroup analysis if this had an impact on clinical outcome?
Yeah, very good question. We have, but the number of cancers is so small that there's no meaningful results. You know, there's hardly any cancers for the people who were at the screening, after the screening, although we have 100,000 people. So I think the study will be too small to look at the individual endoscopists. Maybe at 15 years, I don't know. But we are monitoring that.
And I think one of the problems with screening is that colorectal cancer incidence started to go down before screening started. And,
yes.
This is one aspect, but I think another aspect is also your cohort is pretty young. And with increasing age, there is a proximal shift from colorectal cancer. So I think the benefit for the proximal colon, which can be only be assessed by colonoscopy and not FlexiSig, will come clear in the next 5 to 10 years. Because now the data are pretty similar, like sigmoidoscopy trials.
Yeah, they are.
One other question. Just one other question. Talking about cost reduction in the future, what would you think? We have this low-risk group that we just see every 10 years. What do we do with the histological work? Do you think we still should, when we have these high-resolution endoscopes, still remove the polyp, not send it to a histological report? Because this is another cost factor that is quite high. And we see that actually these patients have almost no risk compared to the others. Just throw these polyps, as we see, they're benign, they're low-grade adenomas just away. Or do we still send them for histological workup?
Good question. I don't know if you want to answer, Thomas or Kaspar. I think, well, you have to resect them. If you believe in the adenomatosis, you remove them, but you look at them with your high D and everything, NBI, and maybe CADEX in the future. You ask the computer, yes, that's not a adenoma, you remove it, you just don't send it.
Well,
that's I think, not now, but in the future, I think that will happen.
I would say the cost here in Switzerland, maybe a colonoscopy costs between 600 and 800 Swiss francs. The histological workup is another 200 Swiss francs per polyp, per specimen you send. So it can be pretty much more costs in one patient, maybe 400 francs more.
I totally agree. I think at some stage we come to the point where we resect and discard if it's less than 10 millimeters.
Well, we
and
could do
at
it
least
now.
one.
We don't need anything below 5. Throw it away.
Yeah.
You don't need AI. Nothing. The risk is so low. Why do you need to confirm here and there? And it's a legal thing, a medical legal thing only.
Yeah.
Absolutely, as long as they don't have any lawyers in the background.
Yeah,
I think it's important that you document.
Joke,
You take a couple of photographs, so you can document and describe it. I think that's important.
I think everybody can wonder when he met the last 5 millimeter polyp, which surprisingly turned out to be cancer. 10 years? Never? So.
Jacques has a question.
This example of what Thomas is saying, so let's say a polyp less than 5 centimeters, there's enough data to actually put this in a guideline. All our guidelines are, the bigger part of what we put in our guidelines is evidence-based. So as soon as we put this in a guideline, it's evidence-based. And then you have proof, and then you can defend yourself against lawyers. It just takes courage. That's the only thing.
I agree.
Maybe we have to follow your approach for Barrett's. That means we just remove all the polyps, but we don't make any follow-up for the low-risk situation like you do for the low-risk Barrett situation, and we use that money and information for more research.
Well, screening works, but surveillance basically
That's
sucks.
what I mean. Surveillance only for high risk, and the rest we just leave completely and look what happens.
If you have one colonoscopy that you can spend on a patient, you rather Michael, would you do a screening in an unscreened patient or severe high-risk patient that has had a colonoscopy before?
That's a good question. I'm not sure how to answer that.
No, don't just do it.
Yeah.
I think so.
Gut feeling, what would you do? Would you do a fit positive screening colonoscopy in that patient in which we find, 40% relevant polyps? Or would you have that patient that had a high-risk polyp cleaned by an adequate endoscopist undergo surveillance for the rest of his life?
I would do the fit positive.
Okay, thank you.
I'm not sure, Jacques, because we are, at least now, we are not doing well with the advanced adenomas.
Well,
So
then,
these are the
we need to
patients we
solve,
need.
then we need to solve that instead of surveying them
Yes.
as a compensation for bad quality treatment.
And
So
the
that's-
excuse that the endoscopist was not good enough, maybe, but
But Michael pointed out the exact reason. We're looking at patient characteristics, whereas probably the biggest determinant is the quality of the endoscopy. And with AI, especially quality-related AI tools, we can basically monitor that and bring that to a certain level. And then at some point, because if you're going to investigate this for surveillance strategies, it will take you ages before you can actually reduce the cost. So I think, at least in our country, we would likely say, okay, at some point, we sit down, we change the guidelines, and we're going to monitor if that cost reduction and cost saving actually pays off, instead of investigating it for ages, for knowing what we already know.
okay, this has to bring us, can we take 2 more questions? Yeah.
A lot about quality of endoscopy, and if I look at my fellows, they all want to become the best gastroenterologist there is. So they all want the best quality. And on the other hand, we're measuring our ADRs, we're measuring our times, how much time we take for a colonoscopy. And we have heard Jacques talk yesterday, and oncologists are getting better and better. Why don't we just stop with the whole screening program and care for the patients that have a problem? And if they come with a symptom, then we can deal with the symptom. And all those asymptomatic, really asymptomatic patients with a very, very low risk for a cancer, why don't we just skip all that and as he said, take the money and spend it on more sensible, more reasonable stuff in medicine?
Before I'm being blamed for killing screening. Screening works.
I know.
Probably the best thing we have done. The question, and Michael's putting it, how do we proceed after that? And what's the optimal screening surveillance? But please, not a 30% risk reduction. Basically, if we would do that if that would be the threshold for everything we do, then I would not be giving these lectures.
Final question?
So if I may follow Jacques' point, is any role in looking for a better marker to decide who should undergo surveillance or not once you identify patients in the screening programs?
No, of course. I mean, and a lot of people are looking. But I'm wondering if there is one.
And
I mean, Kaspar, you are having your basic science stuff. You have had that for 15 years. You are looking, everybody else is looking. I don't know, did you find anything yet?
There are lots of studies, but nothing is really convincing, whether it's the inclusion of lifestyle factors, risk factors, whether it's genetic, epigenetic parameters. So there is no microbiome, maybe in the future in 20 years, but currently there is nothing of all this molecular profiling really benefiting and can tailor our recommendations.
And if so, it's likely to be double as expensive as colonoscopy, a sophisticated lab test. Right?
And it's funny, Thomas, you just mentioned it. Colorectal cancer incidence went up. Now it's went down, 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 down. We have no idea why that happens.
Yes.
And we're looking at all this stuff that you are looking at and everybody else, lifestyle, microbiome. But things are happening. It's gone up and down the last 40 years. We don't know why.
If this will proceed for the next 20 years, the decrease in incidence, then it's even getting
Problem
more
solved.
and more. Then yes,
Okay.
more
We don't know why, but it's
complicated.
solved.
If
Yes.
this gets too melancholic, I think everybody needs a coffee. I'm grateful to the 2 presenters. I think we should follow Jacques' advice and tell the AI not to look at the pit pattern of small polyps, but tell us what not to do. Thank you.